All right, good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Ali, again, as she mentored us last Saturday as well. Dr. Ali is the Medical Director of Allen Psychiatry and TMS Center, as well as Revive IOP and Counseling Center in Allen, Texas. She is an ABPN board-certified psychiatrist and ABPM board-certified in addiction medicine. And now it is my honor to request Dr. Ali to begin today's session. Thank you.
Hello, everyone. I'll continue from our session last time. And if you guys remember, we covered alcohol withdrawal. Today, I will try to cover this topic and complete it quickly so that we can focus on the treatment of alcohol use disorder. So how do you assess for anybody who comes to you with alcohol withdrawal and alcohol use disorder? So I think really cage or tweak is for the alcohol use disorder. Somebody who is not drinking in front of you has come to you, it tells you that I drink often, but I don't know if I really have alcohol use disorder or not. So I think all of you are familiar with the cage or tweak questionnaires. These are two different questionnaires that we use. Tweak is more sensitive than cage. So if you are a primary care doctor, if you are in a setting where alcoholism is not the only thing you're seeing, so cage will be a good one to start. Tweak is more sensitive, where OBGYNs, they use it very often. Why it is important for OBGYN to use the tweak questionnaire. And this is a board style question. You may see this kind of question in your USMLE exams as well. There will be a lady telling you that she just found out that she's pregnant. She drinks a glass of red wine every night, and she is not sure if she should continue or not because she has heard that a glass of red wine every day is actually good for your health. So what is the correct answer? She can drink how much? And then they can give you different choices. The correct choice will always be no alcohol while someone is pregnant. So tweak questionnaire just reminds me of my rotations in the OBGYN floors where they were screening every woman for alcohol use disorder. Alcohol use during pregnancy can be very hazardous. It is a teratogenic substance. It can cause fetal alcohol syndrome. I don't know how many of you have seen fetal alcohol syndrome, but if you see a baby with fetal alcohol syndrome, it's very obvious from their facial features. They have small eyes, they have flat philtrum, this area between your nose and the lips. And they also have developmental delays. As these babies, they grow older, they have more and more psychological issues as well, more impulsivity, ADHD. So it's a combination of physical features, which are more distinctive on their face. If you have worked with a lot of patients with alcohol use disorder, you can recognize any person with fetal alcohol syndrome if you see them somewhere outside. So they have distinctive facial features, just like, you can diagnose somebody with Down syndrome with their facial features. So if you get time today, just go online and look up fetal alcohol syndrome, how these kids look like. And you can prevent that by thoroughly educating all women of childbearing age about the hazardous effects of alcohol while they are pregnant. Tell them not to get pregnant if they are drinking every day. And if they get pregnant, then immediately stop using alcohol. No alcohol at all during pregnancy. Very important question, okay? So you also ask them time of the last use, duration of the use, quantity and frequency of the alcohol use. All these questions can tell you how much of a risk a person is for alcohol withdrawal. Withdrawal associated with 5 to 6 drinks, for example, 80 grams of alcohol per day for a prolonged period of time in patients over 30 years of age. Delirium tremens, usually 16 plus drinks per day for months, but can rekindle in several days of heavy drinking, which means, remember, we talked about the kindling effect, that if you are going into alcohol withdrawal more and more often, it can get worse with time. And history of previous DTs or withdrawal seizures. Again, it's the kindling effect. If you have a history of delirium tremens in the past or seizure in the past, your chances of getting another seizure and going into DTs is even higher. Next slide, please. So types of alcohol use, it's very important to know what kind of alcohol patient is consuming, and it increases their risk. For example, 12 ounces of beer, it contains 5% of the alcohol, 5 ounces of wine, 12%. And then you can see that if it's in moderation, up to 1 drink per day for women and up to 2 drinks per day for men, and only by adults of legal drinking age. It's important to know the legal drinking age because it doesn't matter for people who are abusing alcohol. It can be less than 21 years of age and they can go anywhere, and most of the time it's children reaching out to the alcohol of their parents or accessing it at a friend's house. And then hepatic metabolism, it's different for different people, especially Asian people. They cannot metabolize alcohol as quickly as compared to somebody who's here, Caucasian. So it also depends how good you can metabolize alcohol. So some people, they can have 5 or 6 drinks in one setting and they don't feel anything at all, versus somebody who can start vomiting and throwing up even with just 1 drink. Next slide, please. So the average person metabolizes about 1 standard drink per hour. And again, it can vary from person to person. Excessive drinking, women more than 7 drinks per week or no greater than 4 drinks per day. For men, it is more than 14 drinks per week and no greater than 5 max per day. Binge drinking consumption within 2 hours of 4 or more drinks for women and 5 or more drinks for men. Okay, so it will qualify for the binge eating. Next slide, please. So this is your TWEAK questionnaire. It's very specific. 84% of the time it can screen somebody with alcohol use disorder. So the T stands for tolerance. How many drinks can you hold? 6 or more. Worried, have close friends or relatives worried or complained about your drinking in the past year? Eye opener, do you sometimes take a drink in the morning when you first get up? Amnesia, has a friend or family member ever told you about things you said or did while you were drinking that you could not remember? So remember, amnesia is really like a blackout, okay? You had few drinks and then you were sitting with your friends, you were talking, you were doing things, the next morning you don't remember anything at all. And cut down, this is tricky, you know, K, usually it should be C, you know, cut down, but they're using K. So cut down, do you sometimes feel the need to cut down on your drinking? So you have some insight that, okay, maybe I'm drinking more than I should be. So add up the points corresponding to each positive answer. If TWEAK score is less than 3, patients have low risk for alcohol dependence, stop here. But if the TWEAK score is more than 3, then go on to the step 2. Next slide, please. So this is the risk of developing alcohol withdrawal, age greater than 30 years of age, and check the box if either one is positive. The patient has 4 to 5 drinks per day on average, or one drink is 8 ounce beer, 5 ounce wine, 1 ounce of liquor or equivalent. And the patient had alcohol withdrawal seizures or delirium tremens before. Last drink was less than 3 to 4 days ago. So high risk is all 3 points and low risk is fewer than the 3 points. Okay, next slide, please. So assessment of alcohol withdrawal, detailed history, we talked about that before. And then substance use treatment history, which includes inpatient or outpatient programs, 12-step programs such as Alcoholic Anonymous, or medications such as naltrexone have been helpful or not helpful in the past. Mental health history, comorbid mental illness may impact the patient's withdrawal presentation. Additionally, patients who have the mental illness may benefit from the integrated treatment. Post-withdrawal care that is focused on the dual diagnosis population. So this is important. If somebody is using alcohol to treat their depression or anxiety, insomnia, so very important to take a thorough history so that you can address the cause for which somebody is drinking alcohol. Depression and anxiety are on the top. So make sure that you treat them. Bipolar disorder is also very important. These patients are very impulsive. And because of their bipolar symptoms, they are also more prone to drinking. So make sure that you treat that, start them on Depakote or some other mood stabilizers, which decrease their risk of alcohol use. Next slide, please. And this is, by the way, your only chance of medicating these patients, because these patients will not come to you otherwise. So if they end up in your ER or they are in inpatient, that is your chance to also offer them help for their depression, anxiety, or bipolar. Identification of social supports, family members who can encourage abstinence and potentially dispense withdrawal medications. Very important to educate families, parents, spouse, anyone who is living with the patient, friends. They can also help. Barriers such as homelessness in the patient's life can also help determine the most appropriate for the treatment. A lot of county supported or sponsored residential rehabs are there. We have one over here where we send our patients who have residential problems. They have residential rehab for 30 days or 3 months where patients can stay. So it solves their problem of homelessness, and they also get help. Any physical symptoms out of careful review of the system is important to identify medical problems that can contribute to the patient presentation or worsen the morbidity of withdrawal. And once patients are preoccupied by uncomfortable withdrawal symptoms or develop altered mental status related to their withdrawal, they may not readily volunteer these symptoms. So it's very important to take this history while they have not gone into withdrawal, because once they are in withdrawal, it will be really hard for you to get this history, okay? Because it will also cause altered mental status. Next slide, please. So take a good thorough history. We have already talked about these Symptoms: autonomic hyperactivity, tremors, diaphoresis, anxiety, nausea, increased catecholamines in the urine, serum, and CSF. Hallucinations, most commonly visual hallucinations. Remember, we talked about that last time. Patients will be seeing rabbits or rats or something like that in the room that you can't see, or hear something that you can't hear. And then seizures up to 10%, most common in the first 12 hours and 48 hours after the last drink. Okay, next slide, please. So there are other causes of provoked seizure as well. To keep that in mind, alcohol and drug withdrawal is on the top, but also hyponatremia. Again, these patients are not well hydrated. They have electrolyte imbalance. Hyponatremia can also lead to seizures. Hypomagnesium, hypocalcemia, hypoglycemia. Then in non-ketotic hyperglycemia, uremia, hypoxia, hyperthyroidism, and dialysis disequilibrium syndrome, and porphyria. Next one. So alcohol withdrawal treatment, we talked about that in depth last time. Benzodiazepines, different types of benzodiazepine, long acting, short acting. You have to select which one you are going to use based on the patient's age and demand. And then gradually withdraw or substitute the drug. Supplement vitamins and minerals. Thiamine, very important. I cannot stress enough on thiamine. First thing that you start should be thiamine before even you go for replacing the other electrolytes or giving them dextrose. Folic acid, multivitamins, supportive treatment, and then decrease stimulation, increase fluid and caloric intake. I remember when I was working in VA, in the inpatient unit, they will be really calm. They will be sleeping in their room for the first 1 or 2 days. So they should have a good, calm environment where they can relax and there is less and less stimulation. Next slide, please. Loading dose therapy. I'm not a big fan of loading dose, but keep that in mind. A lot of hospitals, they have this protocol where you will start loading as soon as you see a patient with alcohol withdrawal, 10 to 20 milligram of diazepam every 1 to 2 hours until mildly intoxicated, then will auto taper. So slowly they will keep on giving 10 to 20 milligram of Valium until the patient is completely comfortable, or given the equivalent dose of other benzos. So 25 to 50 milligram of chlorodiazepam, epoxide, or Librium, 1 to 2 milligram of lorazepam. Oxazepam, I've rarely ever seen anybody using that. And SIVA is your biggest tool over here. Make sure that you keep the SIVA score less than 8. Standard taper based on the equivalence with the addition of as needed doses per SIVA. And then it also enables a clinician to quantify the severity of withdrawal and chart progress over time. So SIVA is also your friend to see in which direction your patient is moving. If the score continues to go up, you have to make a decision whether you want to keep the patient in the ER, inpatient, or the patient needs to go to ICU. And it's a very simple test. Whenever you get time, try to do it on each other or find somebody with alcohol use disorder to really learn how to do it. It's important to teach yourself this so that you can teach this to your staff. It takes less than 5 minutes, okay? And it really requires no medical knowledge. These are simple questions that you can ask your patient. Next slide, please. Here you go. So these are the questions that we use for SIVA, nausea, and vomiting. Tremors, and you can ask your patient to, I'm sitting too close to the camera, so you can ask the patient to extend their hands, to extend their arms, and then you ask them to have their fingers apart, and then you can see if they have tremors or what is the intensity of the tremors, okay? Anxiety, agitation, and then sweating, how much they're sweating. It's very obvious in patients with severe withdrawal. You can see them sweating obviously profusely. Next slide, please. Tactile disturbance. Have you experienced any itching, pins and needle sensation, burning or numbness, or feeling of bugs crawling or under your skin? Auditory disturbances. Are you more aware of sounds around you? Are they harsh? Do they startle? Do you hear anything that disturbs you or that you know isn't there? Visual disturbances. Remember, we talked about that. Does the light appear to be too bright? Is its color differently than normal? And then are they seeing anything? Headache. And then the next slide, please. And then the minimal is that you have to keep the SIVA score less than 8. If somebody is scoring less than 8, at that point, you don't need to drug therapy, but 8 to 14, continue to observe patient. Drug therapy is indicated. More than 15, it's severe. It's absolutely aggressively needed. Start the medication. And if it's more than 20, that patient needs to go to ICU. It's impending DTs, okay? So remember these scores. This can be an exam question. They can ask you that you have a patient. I think we had this, we did one of the questions last time. If you have a patient who is scoring less than 8, will you start the medication, or what is your next best step? Next best step is to administer SIVA and see where they are scoring. And based on that, you will determine the treatment and the hospital settings where you will admit the patient. Next slide, please. Again, this is the first thing will be the treatment will be the give thiamine IV 100 milligram. And later on, I also give them 100 milligram TID to prevent Korsakoff. And then you also give them folate, assess the current risk of withdrawal. So in the A slide, you see the CEVA is less than 8. It's low risk. 8 to 15 drinks, you will start the Ativan. Your goal should be to keep CEVA less than 8. You will keep their HR or heart rate less than 100 and their diastolic blood pressure less than 100, okay? And you start, this is the protocol where we are talking about the loading dose where you keep on loading them until the patient is comfortable or all these 3 goals have been met. And you will hold the dose if you start seeing any signs of central nervous system depression, like patients has low heart rate or they are breathing, their respiratory rate is low, you will hold the dose. And CEVA more than 15, you will definitely start considering transferring the patient to ICU. It's better not to take any risk. And your goals of treatments are always CEVA score less than 8, heart rate less than 100, diastolic blood pressure less than 100. It could be a board question, or in your case, it could be a USMLE style question where they can ask you what are the parameters. So remember these things or these 3 goals in mind: CEVA less than 8, heart rate less than 100, diastolic blood pressure less than 100. Next slide, please. Okay, the treatment of mild to moderate alcohol withdrawal, which is between 8 to 15, low risk patients. You can start them on Librium, you can start them on Valium. These are the patients which sometimes can do mobile detox or detox at their home if they have somebody to observe them. And it's very important to teach the family about the CEVA score as well. If there is a patient who is low risk or absolutely refusing to get admitted, patients have a lot of stigma about getting admitted to get treatment for alcohol withdrawal. This is somebody who can be highly functioning, has taken a week off from work and they want to detox from alcohol. These are the low risk patients. You can use Librium or you can use Valium. I do this all the time to finish the detox at home. Short-acting benzodiazepine, lorazepam, 2 to 4 milligram, 1 hour, dosing guidelines, moderate drinkers. And these guidelines, I would say, don't just stick to this one because everybody is so different. So really administer CEVA, and based on the CEVA score, that will be my approach to detoxing any patients from alcohol withdrawal. Next one. Next slide, please. So the treatment of moderate to severe alcohol withdrawal, score more than 15, consider transfer to ICU, lorazepam 2 to 4 milligram IV, Q 15 minutes until stable. Then use that dose of lorazepam that achieve the stability. Standing dose, hold the dose if the respiratory rate is less than 10 or if the patient is unresponsive to voice. So a lot of new residents, they make this mistake of continuously loading them with Ativan to a point where they have snored the patient. Now your patient is really too sleepy, not responding, respiratory rate is less than 10 now, or decrease oximetry. So pulse ox is going down, hold the dose until there is no toxicity and resume at a lower dose. Goals of treatment is always CEVA less than 8, heart rate is less than 100. I'm repeating these because these are the important board questions. So I want that at the end of the presentation, you know all these numbers by heart so that you don't get this question wrong in exam. If this is achieved, total up to 24 hours of lorazepam requirement and split it into Q4 hours or Q6 hours of standing dose for the next 24 hours. And then you start slowly beginning to taper the lorazepam. For the short-acting benzodiazepine, the tapering is more than 5 to 10 days over the period of time of 5 to 10 days, whereas for longer acting ones, you can do 3 to 5 days because Valium will stay in your system for a longer period of time, even if your last dose was like 3 days ago. Next slide, please. Yeah, carbamazepine is also used to reduce rebound withdrawal and post-detox drinking. It is really a good choice for patients with bipolar disorder. And you will see a lot of patients with bipolar disorder and alcohol use disorder dual diagnosis. Gabapentin is really good. I've seen that being used in residential rehabs all the time. It also keeps patient very calm. It is all used off-label for anxiety. It is also used off-label for as a mood stabilizer. So it's really good. And it has no hepatic metabolism. So you can still safely use it in patients who have elevated LFTs, high AST, ALT. You can safely use gabapentin. Gabapentin is treated more like a salt by your kidneys and it is excreted as it is in the urine. So it's a very safe choice. I also like it more than benzodiazepine for my geriatric patients, my older patients with compromised liver function, or even if their liver function is intact, still it's a very safe choice. It also keeps them calm. So the aggressiveness that you see during withdrawal, irritability, that is also calmed down by by gabapentin. Gabapentin is more effective than lorazepam in reducing the post-detox drinking. So a lot of time, the another stigma that with using benzodiazepine is that patients, they don't want to get off of lorazepam or they don't want to get off of Valium. Whereas gabapentin, it's not habit-forming drug. So it's really good even after they finish their detox. And I have a lot of patients who are on gabapentin 300 milligram TID or 600 milligram TID every day to keep them calm and also keep their mood stable. So gabapentin, Depakote, vigabatrin, the other name for vigabatrin is Gabatril. It has also, it has been proven useful. I've seen a lot of psychiatrists use Gabatril. It's an off-label use for insomnia as well. That will not be the answer in the exam. This is just a clinical use. I've seen a lot of patients with resistant insomnia, and you see that a lot in patients. Once they finish the detox, they have REM rebound. So they will come and they will tell you, we are seeing a lot of nightmares, a lot of bad dreams. You just have to educate them that this is all the lost sleep during the alcohol use, and now you are having a REM rebound. Okay, so they have more REM sleep in the first few days after they finish the detox. But keep that in mind that carbamazepine or Depakote or divalproex have limited use in patients with severe hepatic or hematological disease. So you have to be very careful. Carbamazepine is also, it has a lot of interactions because of the P450 inducer. So it can also increase the metabolism of a lot of medications that patients are taking and make them less effective. Very important board style question or USMLE question is the patient is taking carbamazepine, she has come to you and she has missed her periods. Remember that carbamazepine can also affect the oral contraceptive. So it increases the metabolism of oral contraceptive, making them less effective, and your patient can end up getting pregnant while they are taking oral contraceptive. To keep that in mind, educate your patients about that. Next slide, please. So the advantages is we're talking about the anticonvulsants, which are the carbamazepine, Depakote, gabapentin, Gabatril. There is no abuse liability. So these are not habit forming. So your patients cannot abuse them. Less effect on cognition. They are neuroprotective. They will prevent seizures and protected withdrawal disadvantages. Okay, so a lot of these patients, once they finish the alcohol withdrawal, then they are in withdrawal from Valium or lorazepam. So you don't have that kind of liability with by using anticonvulsants. Disadvantages is that it has a limited clinical experience, hematological side effects, and then liver toxicity. All of them, they go through liver, except gabapentin. Gabapentin doesn't go through liver. Very safe medicine to use in patients with liver problems. But Depakote and carbamazepine or divalproex. I'm trying to use generic names because in exam, the generic names are used instead of the market name. So just remember divalproex and carbamazepine. You have to be very careful in patients with compromised liver function. Next slide, please. So alcohol withdrawal delirium diagnosis, disturbance of consciousness, just like any other delirium, inability to focus, sustain, or shift attention, unable to answer your questions. Cognition is impaired. They don't remember where they are. They don't remember when was their last drink. They will be unable to answer you a lot of their questions. Sometimes they're unable to even tell you their name or date. Language, perception, acute and fluctuating course. They can, the delirium has acute and this kind of delirium, the alcohol withdrawal delirium has an acute onset and fluctuating course. Consequence of the substance withdrawal, they could have other substances as well, other than alcohol, which will be causing this kind of delirium. Always remember, alcohol withdrawal delirium is hyperactive delirium. Late and major alcohol withdrawal syndrome, delirium with tremors, most often occurs within the 72 hours after the last drink. Mortality is as high up to 20% if you're not treating it. So it's very important to treat it right away in time. Hallmarks are fever, hallucination, disorientation, delirium, autonomic hyperactivity, high blood pressure, high pulse rate, and hemodynamic instability, associated with increased noradrenergic, serotonergic, and cholinergic activity. Next slide, please. So there is predictors of alcohol withdrawal delirium, prior history of severe alcohol withdrawal, high blood alcohol levels without the signs of intoxication. So this is somebody who has blood alcohol level of maybe 300 or 400, and they are just talking normally to you. These patients are at a high risk of delirium. Withdrawal signs with high blood alcohol levels. So a lot of people, they do the breathalyzer test, and if the blood alcohol, their breath is still positive for alcohol, they assume that they are not at risk of withdrawal. No. If you have withdrawal signs while your blood alcohol level is high, or if your breathalyzer test is still positive, you are at a high risk of alcohol withdrawal delirium. And you also, if somebody is also using Xanax or Valium, along with using alcohol, mixing these two, they are at a higher risk of DTs. Medical problems, hepatitis, pancreatitis, acute pancreatitis is very common in patients who come to ER with alcohol use disorder. So if they come with abdominal pain, the first thing they do is they check their amylase lipase levels. So acute pancreatitis, keep that in mind. Daily heavy and prolonged alcohol consumption, greater number of days since the last drink, and older age. I talked about this before. The DTs is more common in geriatric patients. Hypokalemia, low potassium, thrombocytopenia, elevated blood levels of homocysteine. That is also a very good predictor of alcohol withdrawal delirium. Next slide, please. So how can it be prevented? We talked in length about that. I think it's basically the repetition. And if you are writing the orders, always start the thiamine first, folate, replete the magnesium, correct the electrolyte imbalance. Next slide, please. So lorazepam, it is a drug of choice for sick inpatients, especially patients with compromised liver function. Remember the mnemonic that I taught, out the liver. Oxazepam, temazepam, and lorazepam. These are the medications for patients with compromised liver function, rapid onset, IV, and intermediate half-life, not dependent on hepatic metabolism, and it is available in all forms, IV, IM, PO. Librium or diazepam you can use in young, healthier patients, especially for mobile detox, patients who are at low risk. It has a very long half-life, high hepatic metabolism, so their liver function should be really good. They can also be used in patients with barbiturate withdrawal, respiratory depression risk, and then useful in refractory patients or with co-occurring sedative hypnotic use. Okay, next one. Then transfer to ICU, telemetry. This is for the patients who are already in delirium tremors. So I think this is more, or this slide is more important for our internal medicine residents. You have to protect the airway. Aspiration pneumonia is very common. They vomit and then they aspirate. So make sure that you take those precautions. Oxygen supplementation, intubate if necessary. Respiratory depression can be a cause of death. So they are intubated in the ICU. They have no upper limit for lorazepam dose, and they keep on dosing them until they bring the CVA score less than 8. May add clonidine, beta blockers if there is high blood pressure or tachycardia. May use Haldol if hallucinations are there. Haldol can also prevent them from going into physical restraints, because if they don't respond well to lorazepam and they go into hyperactive delirium, what do? They start taking out the IVs. They are very aggressive. So better to start them on Haldol if on the first sign of aggression. It will prevent your patient from going into physical restraints. Okay. And then the thiamine will always be first, because if you don't give thiamine and start the dextrose first, you can cause Wernicke's and Korsakoff to your patient. Next one. Next slide, please. Okay, here you go. Board love these questions about Wernicke's and Korsakoff, so make sure that you know everything about it. You will get a lot of questions on this. You will be tested on in USMLE as well on these questions on Wernicke's and Korsakoff. Delirium due to thiamine deficiency is less than it's rare in less than 35 years of age patients. Acute symptoms, it is reversible with the treatment. Triad is ataxia. Nystagmus, usually vertical nystagmus. Remember that. Board loves to ask this question, vertical or horizontal nystagmus. They will ask you these kind of questions. Ophthalmoplegia, you will treat it with thiamine, 100 milligram IV or IV times 3. And then after that, you will continue it for 2 weeks. Korsakoff syndrome, impaired short-term memory. It is a sequela of Wernicke's. When Wernicke's is not treated, it gets worse. It leads to Korsakoff chronic condition, 20% recovery rate, which is really good. So you do not give up on a patient who's already showing signs of Korsakoff's. And there is interrograde amnesia and alert responsive patients. Confabulations are present. The treatment is again thiamine, 100 milligram TID for the next 3 to 12 months. I had a very interesting case where a patient was referred to me by a therapist. They thought the patient had OCD. Patient had graphic confabulations, like patient thought he had killed somebody, or he has raped someone, he has done something really terrible. But when he would look in his security cameras in the home, he was at home whole time. So it was not even possible that he had done something like that. But when I took the thorough history, I found out that this patient had heavy history of alcohol use, and then he stopped using abruptly. Didn't go through any sort of withdrawal. Even if he went through the withdrawal, he tolerated it well. So I started him on a low dose SSRIs. I started him on fluvoxamine for those intrusive thoughts because we were treating it initially as OCD, but I still started him on thiamine. He was one of those lucky 20% patients who recovered. So after a year, he's off of SSRIs now because he had no previous history of OCDs or any intrusive thoughts. So sometimes you will see patients. There's also a book, I think the title was Almost Alcoholics. This patient had no other symptoms except confabulations, which were very graphic. So a thorough history can help you guide in the right direction instead of just treating the OCD. Adding thiamine helped him so much. Next slide, please. So thiamine is an important cofactor for several enzymatic reactions, cerebral glucose utilization and glutamate elimination. So when you don't give thiamine, or these patients who use alcohol, they have deficiency of thiamine, can lead to the Wernicke's, which is confusion, ataxia. Again, these I'm repeating this because these are the board questions: confusion, ataxia, and nystagmus. Mental disturbances, mortality 10 to 20% if untreated. And then treatment is so simple: thiamine replacement prior to dextrose administration. And then Korsakoff's, anterograde amnesia, and confabulations. Next slide, please. Confabulation is really, filling the memory gaps. When they don't remember something, the brain fills that gap with some memories. These are made up memories. So that really something that really not happened. And the board can ask you the question that where is the pathology when you have a patient with the symptoms of Korsakoff. They may not tell you that it's Korsakoff. They can tell you that you are seeing a patient with anterograde amnesia and confabulation. Where do you think that the pathology is? So remember, mammillary bodies, okay? This is a USMLE style question. Next slide, please. These are the clinical cases. I think we did it last time. So let's move to the clinical case 5. We have done the first 4 clinical cases last time. So you can move the slide to clinical case 5. Here you go. Can you go back? Yes, here. So this is a very important question. A 52-year-old anesthesiologist wants to start disulfiram to avoid drinking as part of his monitoring by the medical board. Which of the following enzyme is inhibited by disulfiram? So the choice A is alcohol dehydrogenase, aldehyde dehydrogenase, sulfuryl dehydrogenase, glucose 6-phosphatase, E-acetate dehydrogenase. So dehydrogenase is the last part. The first part is very important, so you have to memorize this. You will be able to answer this question once we finish this presentation today. Move on to the next slide, please. The symptoms associated with acute alcohol withdrawal are related to overactivity of which of the neurotransmitter? I think all of you should be able to answer this question now. We talked a lot about that. Remember that seesaw slide? One side was GABA, one side was glutamate. So the correct answer to that is glutamate. I'm giving this away because we have already talked about that. Next slide, please. A 64-year-old elementary school teacher with alcohol use disorders, severe, and a creatinine clearance lower than 30 milliliter per minute wants to be started on pharmacotherapy to aid her in her recovery process. Which of the following medication is most strongly contraindicated in patients with advanced renal disease? So this is I think this is a very easy question. When they are talking about creatinine clearance, when they are talking about advanced renal disease, really it's a very easy question. They want you to start a medication which has no adverse effects on the kidneys, okay? Or they want you to avoid a medication that has very bad effects on the kidneys, okay? So the choice is acamprol or acamprosate. Acamprol is the market name for this medication. Buprenorphine, the market name is Suboxone or sometimes Subutex. Disulfiram, antabuse, commonly called antabuse. D is sertraline, market name is Zoloft, it's an antidepressant. E is naltrexone, okay? Next slide, please. Okay, so pharmacotherapy of alcohol use disorders, all those of you who are not going into psychiatry, it's very important for you to learn this here because this is your chance to help somebody with alcohol use disorder later on in your life if you're treating somebody. We use these medications very commonly, and I've seen that doctors, especially those who don't understand how these medications work, they don't even offer it to their patients, which is a big drawback. Not all the patients with alcohol use disorder, they come to psychiatrists. They may be seeing their OBGYN, they may be seeing their primary care physician and sharing with them that I think I need something to help me with limiting my alcohol use. What can I do? So these are the medications. These are really good medications. If you know how this medication works, you know the mechanism of action, you know the contraindications, you can offer it to your patient, you can help somebody really quit drinking. Disulfiram or antabuse, the dose is 125 to 500 milligram oral per day. Really, this is more of a fear-producing medicine. Disulfiram is the medicine that makes you very sick. If you're taking disulfiram and you drink alcohol, you will become very, very sick. We will talk about that. Acamprol or acamprosate, the dose is really strange, 666 milligram 3 times a day. Or sometimes you have to just remember a number, remember the number 3. So it also comes in 333 milligram, 333 milligram, 2 tabs, 3 times a day. That is the, I think, biggest limiting factor for acamprol, because a lot of time patients forget to take this medication. Naltrexone, 50 milligram per day. Naltrexone is a very useful medicine. We will talk about that. And then naltrexone XR or intramuscular dose, 380 milligram. It only comes in this one dose. The market name is Vivitrol. Vivitrol is an excellent medicine. If you have a patient with good liver function test, you can start them on this monthly injection. Patients love it because then they don't have to remember taking the medicine every day or worrying about taking the medicine every day. And you can send them to the pharmacies. You don't even have to give the injection yourself. If you are not comfortable, you are in outpatient practice, just send them to Tom Thumb, Brookshire. These are the pharmacies where the pharmacist will give the injection to the patient. All you have to do is to send the prescription there. It is covered very well by the insurance companies. So it's a good, affordable medicine if you have health insurance. What parameters are used to determine treatment efficacy of alcohol use disorder? How do you know if the medicine is working or not? Remember, we talked about this, that every time a patient comes to you with relapse, treat them just like you will treat somebody with diabetes or high blood pressure, right? Every time they have a relapse, it's a learning opportunity for you to learn and see what has worked for this patient and what has not worked for this patient. Let's say you have started somebody on naltrexone, and then you watch how many days that this patient has stayed abstinent before their next relapse, and it will tell you if the medication was effective or not. Let's say you started somebody on naltrexone and they relapsed within a week. The medicine is not working at this point. You can use 2 or 3 different medications, and you can use all 3 or 4 of them together as well. Person days of heavy drinking, how many days you were drinking heavily, likelihood of any drinking, likelihood of heavy drinking, drinks per drinking day. So maybe they are taking naltrexone, so they have not completely stopped drinking alcohol, but previously if they were having 5 drinks or 4 drinks per day, now they only use 1. Why? Because naltrexone blocks that reward pathway. And that is another board style question. They will ask you which part of the brain. Nucleus accumbens. Nucleus accumbens is your reward center in the brain. Remember this for your board exam. That's where the naltrexone works. It blocks that reward center. So now you are not getting the same reward that you were after drinking alcohol. So alcohol is no more as fun as it was before. So it will not give you that same satisfaction. So you will not drink more than 1 or 2. After that, you realize it's not helping. And then time to first drink or relapse, consequences of drinking, and then the biological markers. Biological markers could be your AST or ALT, how much that is improved. And then another board style question could be, it's not in the slide, that you know how some diabetic patients, they continue to use cookies and cakes and all the sweet product, and then they want to show their doctor that they are really good and their blood glucose level that day is good. But if you look at their hemoglobin A1C, it tells you how much of the sweets or sugar control, or how good their sugar control was for the past 3 months. For alcoholic patients, they can stop drinking for 1 or 2 days, and you check their drug screen, it comes back negative, and you are like, okay, this patient has stopped using alcohol. Always check look at their liver enzymes. If the liver enzymes are still elevated, it might be an indication that they are still drinking alcohol. You can also check their GGT levels and their CDT levels. So remember these 2 enzymes, GGT and CDT. CDT is more specific. GGT is more sensitive. Next one. Next slide, please. Okay, this is a very important slide. If you look at it, you will realize how important it is for you guys to learn this today so that you can offer it to more and more of your patients. 17.6 million people suffer from alcohol use disorder. And look at this, how many of them actually seek treatment? Only 2.2%. Okay. And then out of that, 2.2 million, and out of that, only 0.1 will be offered medications to help with the alcohol use disorder. So these medications that I'm talking about, antabuse, naltrexone, acamprol, only 0.1% of the patients are offered this treatment when they come to you. So if you learn these medications today, we can at least improve this number. This number can go up. Next slide, please. So higher relapse rate with the psychosocial support alone. So if you don't offer them these pharmacotherapies like naltrexone or acamprol, they will the relapse rate is really high. Just psychosocial support is not enough. 50% at 12 months, 50% of the patients will relapse within 12 months, within a year, and 90% of them will relapse at 48 months. See, we can reduce these numbers if we can start offering medications to our patients. Poor medication adherence is common and associated with higher relapse rate. So you can address them by offering them which one? Out of all the choices, Vivitrol once a month injection, you're done. So you can solve this problem if you can, especially our primary care physicians, they can benefit a lot from offering this medication to your patients, just once a month shot. So just send it to Tom Thumb and Brookshire, and then the patient is taken care of. Consider adding medications in active alcohol use disorder if they have stopped but experiencing cravings and slips. So I really don't start anybody on naltrexone or acamprol or all these medications the first 2 or 3 days of their withdrawal. Why? Because they are already going through withdrawal. They already have nausea. So if they feel bad, they will associate that with the medication use. So naltrexone itself can cause nausea. I tell my patients to take it with food. So try to do it when patient has finished the detox and they're still on the floor. You have not discharged them yet. You can, at that time when they are more alert, they are more active, their cognition is better, they have finished the detox, you're moving towards discharging the patient. This is the time when you can initiate the discussion of starting acamprol or naltrexone and offering them all this help, educate them about it, and a lot of patients will be very happy. They don't even know that there is pharmacotherapy for alcohol use disorders. Next slide, please. So disulfiram, let's talk about that. It inhibits the metabolism of aldehyde dehydrogenase. So remember this aldehyde part. This is the giveaway for the question that we talked about earlier. So the board will, or the USMLE, you can see these kind of questions. They love these questions. They can give you alcohol dehydrogenase or glucose 6 dehydrogenase or acetate dehydrogenase. Just remember the word aldehyde, okay? So what happens is when it inhibits the metabolism, or it inhibits this enzyme aldehyde dehydrogenase, there will be more and more acetaldehyde accumulation in your body. Unpleasant physical symptoms on exposure to alcohol. So if you will drink alcohol, it will not be metabolized. This step will be stopped here, and the patient will get very, very sick. And this reaction is as quick as within 10 to 15 minutes. Reaction can be quite severe, occasionally fatal. Severity is related to dose and individual characteristics. Disulfiram acts as an aversive agent, so it's an aversive therapy. Patients who are taking disulfiram, and even if they have used a little bit of alcohol, they know how bad it makes them feel. They have nausea, vomiting, discomfort, so they will not even touch alcohol because they know how sick they will become with alcohol. Since disulfiram works, it works via the fear of its effect. Low doses can be as effective as higher doses. I have never given anybody more than 125 to 200 milligram per day. The other thing is I'm also worried about the liver function test. So as I said before, that it can be, if you continue to drink alcohol in spite of using antabuse, you can get very, very sick, and it can be fatal. It can lead to liver failure as well. When I start anybody on disulfiram, I check their liver function once a month for the first 3 months, and then you can start checking it every 6 months or once in a year, okay? Depending on how long they are using it. Disulfiram is usually my last choice. I use it for patients who need to be absolutely sober, like they cannot, they are not functioning, they are at the verge of a divorce, they have a police case, they have a legal case going on, they have a DUI, so driving under influence. Now they have they can go to jail for that. And now their problem is that not only they are putting their own life at risk, they are putting other people's life at risk. And disulfiram gets the job done really good. Keep in mind, there is another board style question, metronidazole or Flagyl. It acts like disulfiram. It does the same thing. So if somebody is taking Flagyl and they end up drinking, they can get very, very sick. And a typical board style question is that you have a female who has history of, who's telling you all the symptoms of a sexually transmitted disease or some other symptoms, and you have started that patient on Flagyl. The patient comes back to you, now she's really sick, vomiting, she's in the ER. What do you think has caused this? So this patient was not honest about her drinking to her OBGYN, or was not honest about her drinking to her primary care physician, didn't mention to the primary care physician, do you drink alcohol? No, when she was drinking. And now she has started flagyl and had a drink, ended up getting really sick. Not only alcohol, these are the patients who will get very sick even if they are on a gas station and they have smelled few fumes of some fumes over there, or these are the patients who are at an Italian restaurant, or the wine was used in cooking, or they have used some sort of alcohol while cooking. They can even get sick by eating or trying Italian food. So keep that in mind, educate your patient very well before you start them on antibiotics. It's very important that they understand all these side effects. What I do is I sometimes give them a printout or send them an email with all these side effects and with all these things to expect, so that they don't mistakenly eat something or take something, or even the perfume, alcohol containing perfume, they put them that on and they can get very, very sick from that. Next slide, please. So the other side effects are dermatitis, garlicky or metallic taste. Patients complain of metallic taste even with flagyl. Most serious side effects are hepatic or hepatitis, peripheral neuropathy, optic neuritis, and then it can also cause depression, psychotic disorder, exacerbation. Remedy is to do baseline and follow up LFTs, check the LFTs on these patients. Severe hepatotoxicity frequently occurs early on. So getting LFTs more often early on in the course of treatment is recommended, as I said, once a month. Use in motivated and reliable patients only. So don't give it to somebody who's not really ready to quit drinking, okay? And you can look up, I don't have time right now to go over that. There are different changes, there are different stages of change, pre-contemplation, contemplation. So look them up, and you have to figure out at what stage of change your patient is on. If your patient is fully motivated and they are ready, only then give them disulfiram. As I said, this is my last choice. I only use it on patients who can no longer afford to continue to drink. They get into very serious legal, physical, or social trouble if they continue to use. Next slide, please. Again, alcohol containing products or paraldehyde within 14 days of discontinuing disulfiram. So this one is very important. You tell your patient that do not resume drinking or eating or consuming any alcohol product even after 14 days of discontinuing disulfiram or antibiotics. So even if they have stopped using, they cannot start drinking in a week. They have to wait for 14 days, because if they do that, they can still get very sick. Recent use of metronidazole, flagyl, we talked about that. Severe coronary occlusion or myocardial disease, avoid disulfiram in those patients, and hypersensitivity to disulfiram, okay? Or other theorem derivatives used in pesticide and rubber vulcanization. This is not as important. I have never seen this kind of question in exam. And then psychosis, obviously you are not going to give disulfiram to a psychotic patient. Next slide, please. Now, this is an important slide, acamprosate or acamprol. It may balance the glutamate overactivity, thus reducing the potential for relapse. So what happens, remember these, we talked about this balance that is disturbed. In a normal person, there is a balance of the inhibitory neurotransmitter, which is GABA, and excitatory neurotransmitter, which is glutamate. What alcohol does, it causes more of the GABA neurotransmitter potentiation, and then intolerance. Even if you are drinking a lot of alcohol, you still have the GABA effect is not as pronounced. And as soon as you go into withdrawal, in order to adapt, you will see that higher glutamate activity. And even in post-acute withdrawal, and these are the patients who will drive in front of a gas station from where they used to buy alcohol, or they are in a situation where they use alcohol more common. A lot of lawyers and business bankers, they tell me that they have to drink with their clients. The lawyers, they don't have to drink. Lawyers don't drink with their clients, but they have their get-togethers where they have to drink with their colleagues. So it reminds them of the same situation. So alcohol use disorder patients, these are the patients to whom I tell you have to be 100% abstinent, because if you take one drink, you are not one of those people who can stop after one drink. So they don't have to drink at all when they are with their colleagues or they are out there. So it's really hard for them in those situations to say no. Because of the increased glutaminergic activity as well. The glutamate receptors and transmission, moderation of the prolonged withdrawal, insomnia, fatigue, mood liability, anxiety. So acamprol helps with that. it is working. It works pretty much as an NMD antagonist, so it is really minimizing the effects of glutamate. And if you look at the European data, more than 3,000 subjects superior to placebo in maintaining the abstinence. So it has really good effects for abstinence. And you can combine acamprol and naltrexone. There's no problem with that. Optimal treatment. So if you combine that acamprol plus naltrexone plus the psychosocial therapies, like 12 steps, it gives you the maximum results. Next slide, please. Relapse and conditioning. Repeated alcohol use has caused the conditioning to occur, as I talked about the situations where they used to drink. Now cues associated with alcohol use can activate the reward and withdrawal circuit. This can evoke the intensification of alcohol or feeling similar to withdrawal that can precipitate a relapse in an abstinent patient. So maintenance of abstinence from alcohol in patients with alcohol dependence who are abstinent at the treatment initiation should be part of a comprehensive management program that includes psychosocial support. Remember, we talked about that. Offer it to your patient who is now preparing to discharge from your inpatient unit. And precaution, acamprosate does not eliminate or diminish acute withdrawal symptoms. So it cannot cause or make the withdrawal worse, and it cannot help with the withdrawal either. Next one. Initiate as soon as possible after the alcohol withdrawal when patient achieves the abstinence. Maintain the treatment if patient relapses. So you can continue acamprol even if your patient is in withdrawal, unlike naltrexone. You will stop naltrexone if patient is in withdrawal. Recommended dose is 2 tablets of 333 milligram tablets 3 times a day. So 3 is the number, big number to remember. Eliminate via kidney. So this will give away the answer to that question. So the metabolism is through kidneys, not through liver. So if you have a patient with compromised renal function or renal impairment, you have to be very careful. You have to either reduce the dose or you have to completely stop if they have the creatinine clearance of less than 30 to 50 milliliter per minute. This could be a USMLE question, so remember that. It can be taken with or without meals. You don't have to take food while taking this medication. I mentioned this because for naltrexone, I tell patients to take it on, do not take it on empty stomach, take it with food because it can cause nausea. Whereas acamprol is very safe, you can take it on empty stomach. Next slide, please. So the safety, advantages and disadvantages, keep that, learn all these things so that when you know a medication well, it's easier for you to offer it to your patients. Won't make you sick if you drink. So a lot of time patients, they don't know the difference between acamprol, naltrexone or disulfiram. So they're worried about getting sick. So they're going to ask you this question, will this medicine make me sick if I drink alcohol? No, even if you have taken the 666 milligram of alcohol acamprol 3 times a day and you take alcohol, you will still not get sick. May reduce the desire to drink. Helpful for those with liver disease. So you have a patient who has compromised liver function and now you cannot offer them naltrexone or disulfiram. Both of them are metabolized through liver. You can offer them acamprol. So really know the difference between acamprol and disulfiram with liver and renal function compromise in patients. Increased likelihood of abstinence, so it will help them staying abstinent. It has a relatively small effects size, so we don't really know how effective it is. There are good data out there, but it's still not enough. It requires 3 times daily dosing, so that is another disadvantage. Patients, they can forget to take it. Okay. Next slide, please. So the question, now we will come to the questions. A 52-year-old anesthesiologist wants to start disulfiram to avoid drinking as part of his monitoring by the medical board. Which of the following enzymes inhibited by the disulfiram? Aldehyde dehydrogenase. This was the correct answer. Next slide. We already discussed that glutamate is the major excitatory neurotransmitter in the brain. However, excessive glutamate can lead to neurotoxicity. So evidence suggests that the hyperglutaminergic brain state is the core pathology behind alcohol withdrawal syndrome. Okay. So this hyperglutaminergic state results from upregulation of glutamate receptors, dysregulation of glutamate metabolism, and reduction of synaptic glutamate clearance. Okay. So this is very important to remember because that's why acamprol is more effective in patients with alcohol abstinence. It works on these receptors. Okay. Next slide, please. So a 64-year-old elementary school teacher with alcohol use disorder severe and a creatinine clearance lower than 30 ml per minute wants to be started on pharmacotherapy to aid her in her recovery process. Which of the following medication is the most strongly contraindicated in patients with advanced renal disease? So whenever a board or your USMLE question is telling you or giving you numbers like giving you AST, ALT numbers, elevated AST, ALT, or they are giving you creatinine clearance, or they are telling you the patient is on dialysis, or patient has liver transplant, they're asking you which medication is safe in patients with liver problems, or which medication is safe with renal problems. So pay attention to these questions. These are easy giveaways. You can score really high if you know this, the mechanism of action of all these medications. So remember, acamprol. So which of the following medications most strongly contraindicated? That will be acamprol. They are already giving you the number 30 ml per minute. Do not give acamprol to a patient with compromised renal failure. Another question could be, which one will be preferred medication in this patient? So I think naltrexone will be a better choice, right? And naltrexone will be a good choice for this patient because naltrexone goes through your liver. So this could be a good board question. Next slide, please. So acamprosate has been used in Europe for the treatment of alcohol use disorder since 1989. In 2004, it became the third drug to receive approval from the FDA for alcohol use disorder. So, the FDA will only approve it if we have enough evidence that it is helpful. Structural analog of GABA believed to decrease alcohol intake by affecting calcium channels and modifying transmission along GABA and glutamate pathways in the brain, resulting in a decreased positive reinforcement of alcohol intake and decreased withdrawal cravings. We have talked about the dose already, 666 milligram 3 times a day. The dose can be reduced. Actually, I don't start anybody on 666 milligram 3 times a day. I always start with a low dose first to see how well they tolerate it, and then I go up to 666 milligram 3 times a day. It can be reduced to one POTID tablet in patients with moderate renal failure. So if somebody has creatinine clearance of less than is around 30 to 50 ml per minute, or even less than that, I will really not use it at all in any patient with a little bit of renal problems, because we have other choices. And it's contraindicated in patients with severe renal impairment. And then acamprosate does not need to be discontinued in the event of relapse, which is unlike naltrexone. Next slide, please. All right, so this is really end of the lecture. Before I end this lecture, I want to talk about naltrexone. I didn't include the naltrexone slides over here because I thought I wouldn't have enough time. I was supposed to only prepare 60 slides. So by the time I reached to 70 slides, I didn't mention it. There are a few important points that I want to talk about naltrexone. Naltrexone is an opioid receptor antagonist, okay? So that's how it stops or blocks the reward system in your brain. So naltrexone is also used for opioid dependence. Remember one thing about naltrexone, it can give a false positive for opioids. So I had a few patients, because, in order to block opioid receptor, if somebody has to be an opioid antagonist, it has to look like, structurally, it has to look like an opioid, right? So it can give a false positive on a drug screen. So I have patients who are living in halfway houses. These are the homes which are especially for the patients who have homelessness or who have problems with residential because of their drinking. So these are housing that are offered to these patients, and they have this condition. They will be kicked out of their halfway house if their drug screen comes positive for any illicit drug use. So these patients with naltrexone, sometimes it gives a false positive. And if you know that as a physician, I have given letters to my patients telling their managers at their halfway house, or telling their family members, because sometimes wife can be doing a drug screen at home, or parents can be doing that. And if it's positive for opioids, I tell them it can be a false positive. And at that point, I do a comprehensive drug screen with gas chromatography, because gas chromatography can actually differentiate between a real positive for opioid or a false positive. So naltrexone can give a false positive, and that's where you can be a very good help to your patient, because nobody is trusting them. These are the patients who have burned the bridges. So at that point, if you know this fact that naltrexone can give false positive, you can help your patient. You can order a comprehensive drug screen, and you can help them being thrown out of their home or thrown out of their halfway house. Okay. So this is the end of the lecture. Thank you very much. I think I finished in time. I'm right on time. I finished in time today. Hamza, I cannot hear you. I think
Sorry about that. It was not letting me unmute.
Okay.
I just fixed that. So thank you for your mentorship and teaching, Dr. Ali. We will begin our Q&A session now. My name is Hamza. I'm a BSDO student at Seton Hill University, and the BSDO program I'm in is with the Lake Erie College of Osteopathic Medicine, both in Pennsylvania. To start off our Q&A, the students would like to learn more about what a typical day in your career is like. As in, do you see patients every day? And if so, what are your hours? And if it is in the inpatient or outpatient setting?
So, Hamza, I usually do the outpatient practice. I've done a lot of inpatient initially when I first finished my residency. There are pros and cons for both. I'm in private practice now. Private practice gave me more flexibility. My kids were little when I graduated, so I wanted a more flexible schedule. Inpatient was also good. You are done by 5 p.m. If you're not taking a call. If you're an on-call doctor, then you have to stay on the campus. If you are working in inpatient, you will be seeing a lot of patients with alcohol use disorder, with other substance use disorders, especially post-COVID. You will see a lot of patients with depression, mental health issues are getting more attention now. There is increase in awareness, so it's a lot in demand. So in inpatient, you will see more serious pathologies. Like I have medical students who rotate with me, and they usually see calm, stable patient. And I tell them, I have a very boring practice. If you really like to see something fun, go to Psych ER or go to inpatient, because over there you will see more psychotic patients. These are the patients that police will bring to you. They were about to jump off a bridge, or a manic patient from the street. The police will pick them up and will bring them to the state hospital or other psych facilities. So if you want to see more acute form of psychiatry, you can work in inpatient and see all those kind of patients. In outpatient, because it's a private practice, I mostly see patients with private health insurance. These are the patients who are maintaining their jobs. So these are the patients who are highly functioning, and they are now struggling because of their depression or anxiety or alcohol use or opioid use. The thing that really struck me after COVID was that I saw a lot of healthcare workers. I started seeing more and more nurses and doctors coming to me, because we are some people in medical field, we don't take care of our health very well. We are very good preachers, but when it comes to our own health, we don't seek help. I saw that a lot post-COVID. I started seeing more and more physicians, more nurses, more healthcare workers who were going through a lot of stress. They relapsed. And definitely nurses and doctors, they have more access to the opioids, right? They have more access to a lot of these medications that can also be abused. So that is the main difference that I see in inpatient and outpatient. And a usual day is really good for me. Most of my patients, I've been in practice since in private practice since 2014. So most of my patients are the patients who have been seeing me now for 7 to 8 years. And they are stable, they are in the stable mode. So they just see me for continuing the medication. I see a lot of Suboxone patients. Suboxone patients have to be seen every month. The Suboxone is the market name. The generic name is buprenorphine. With a combination of naltrexone. And here's another important thing about naltrexone. Naltrexone is also used off-label for cutting. A lot of patients with cutting behavior. Why do the patients cut? It is also an impulse, right? A lot of patients, they cut their wrist. You will see a lot of teenagers. And I do this. If they come to my office in person, I tell them, can you show me your wrist? If they are talking, if they are very depressed and if they are very down and they are not giving me a clear answer about self-harm, so self-harm doesn't always mean suicide. Self-harm also means, hurting yourself in any way. So I have patients, I will tell them, show me your wrist. So the wrist can tell you a lot about a patient. If you are somebody on a ICU floor or in inpatient and you are giving an IV and you see the scars on their wrist, always rule out that if they're still doing it or if they still have depression. So naltrexone is also used as for cutting behavior. It is also used for binge eating. So there is a drug known as Contrave, which is a combination of Wellbutrin and naltrexone. It is used for weight loss. So it is used for all sort of impulsive behavior. So I see a lot of patients like that. I see patients with comorbidities, like patients who have both drink substance use issues plus depression or bipolar or binge eating disorders. So a usual day is really a combination of all these. I don't see too much of substance use in my practice. I only see it on the IOP side because we also have an intensive outpatient program, a partial hospital program. So I see more of those patients over there. who have finished the detox, who have finished an inpatient residential rehab, and now they have been stepped down to IOP or PHP. But on my medication management side, I'd see more of a treatment-resistant depression. I'm also an interventional psychiatrist, which means I do interventions like TMS, transcranial magnetic stimulation. I also do esketamine treatments. So on usual day, I'm seeing more of the treatment-resistant depression. I also get referrals from other psychiatrists who don't have a TMS machine, because I don't know how familiar you guys are with transcranial magnetic stimulation. It is a treatment for treatment-resistant depression. Transcranial magnetic stimulation is also FDA approved for smoking cessation. It is a treatment which is getting very popular. It has been FDA approved since 2008 for treatment-resistant depression. So it's a big machine. It's like an MRI machine, and you need a special room and special plug to plug the machine in. So it is replacing, or it is providing an alternative to electric shock treatment, or ECT. So I do that a lot. I get a lot of referrals from other psychiatrists for that. It is, and there are a lot of trials going on. I think I'm expecting that we'll get FDA approval even for substance use disorder, since it already got FDA approval for smoking cessation. So it works on the prefrontal cortex, the part of the brain that controls your mood. So we are hoping that in the coming years, we will get FDA approval for substance use disorder as well, and we'll start offering that to our patients too.
All right. So you mentioned specifically how you work only in outpatient care. How would you know if your patient is high risk enough that they need to be sent to inpatient care? Is there anything that puts that out?
Yes, I do that all the time. So let's say a patient has come to me for a regular 20, 30-minute follow-up. I'm talking to the patient, now patients, and you can visibly see the signs of withdrawal. You can also, if patient is not in withdrawal, they are drunk, you can see those signs too, because patients they have a disinhibited behavior, okay? So they may be talking the way, slurred speech, talking in a way that you will tell that your patient is under the influence. I don't know, have you ever seen, ask this question yourself, have you ever seen a person that talks differently when they are drunk? You might have seen some colleagues in a party or in a function where you can tell that they are under the influence of alcohol. So if I see a patient like this, I ask them question. And again, SIVA is the best thing. I ask them, how many drinks you had? Are you doing okay? I can help you. I'm not here to judge you. I'm here to help you. So tell me about that. And if I feel like, okay, they are drunk, I will like, do you have somebody at home? Are you alone? If they have a parent, or if they have a wife or somebody over there, I request them to let me talk to them. I talk to them. I educated them. Listen, you need to take your son to the hospital. Listen, you need to take your husband to the hospital. I think he will need inpatient to detox. Really, you have to help him. And at that point, family is your biggest help. When my patients, they fill out their forms, I always get their emergency contact. I also get the names of the individuals who are on the HIPAA release form. So you can that is your biggest help. And you can intervene if you feel like your patient is at a risk, that HIPAA can be compromised in the situation where you feel like your patient is at a risk of harming themselves or harming others. So if this is a patient who is planning to go out and drive on the road, he's not only risking his own life, he's also risking lives of other people on the road. At that point, you have to intervene. Call the family. If you have any contact information, do that. If a patient is really acting out, they are drunk, we do the wellness check. So I call 911, we do that. My office is doing that all the time. Obviously, I have patients, I have to move on. So my staff is well trained. They call 911, they tell them that this is a patient that we think is at a risk to himself or others. Can you please do a wellness check? And then the police goes over there, they check on the patient. And oftentimes, they are the ones who will take the patient to the hospital. And that can be avoided really if you educate your patients well, and the family member can take them, because when the police takes the patient, they have to handcuff everybody. So it's not a pleasant situation. You don't want the police to do that. You really want the family member, the mother or father or spouse, to take the patient to the hospital instead of calling 911. I'd only do that if the patient is alone, they are living by themselves. At that point, I have no other choice, or if I cannot reach out to the family member. And you also have to rule out if the patient is an imminent threat. Okay. So if somebody is drunk to a point where you feel like they are an imminent threat to themselves, at that point, you will just call 911. I have patients, now I see mostly patients on tele, but before COVID, I had patients who had come drunk to my office, and I have a special area for them. So I take them there. I have a staff member sit with them until I take their car keys. I don't let them drive back. So I've done that. I've restrained them in my office and called their wife or spouse, or called 911 to get them help. Do whatever you have to do to save your patient.
Now, you mentioned earlier when you answer the first question that you do treat teens who may be cutting. So do you manage generally acute pediatric or adolescent care? We also are curious to learn if the shortage of psychiatric beds is also a problem in Texas as it is in the East Coast states.
Yeah, think about that, Hamza. Practicing in an outpatient facility is not easy, especially private practice. Okay, as I said, these are the patients who have private insurance plans. They're highly demanding. Sadly stopped taking new patients, new adolescents, teenagers patients in January 2021 because post-COVID, the dilemma was anytime we had a long wait list anyway, but anytime we will open a new patient slot, it was taken by a teenager. And teenagers are really hard to treat. It increases the workload on my administrative staff because then you are preparing letters for the teachers, you are preparing letter for the staff. It's very hard to deal with children when you have parents involved because a lot of time the parents have more problems than the children, and you can't fix that. We had situations where on the front desk parents were fighting with each other, divorced parents. If the co-payment is $25, one parent will pay $12 and a few cents and will say they get the other amount of co-payment from the other parent, and the child is standing there, and I'm like, really these parents need more help than the kid. So I stopped taking new teenage patients because it was taking a toll. I have children myself at home. I had my own reasons not to see children. It's really hard. And then I'm sure you guys know as medical student, if you don't, then you should know that the suicide rate has doubled in the past 10 years for teenagers. It's heartbreaking. 13-year-old, 14-year-old committing suicide, even younger than that. So it takes a toll on you. I think we need more reforms in the practice of psychiatry. It's really hard not only to, first of all, there's a shortage of psychiatrists, there's a shortage of places. For teenagers, it's even worse. It's so hard. Sometimes I had to transfer patient 2 hours away to Fort Worth. My practice is in Allen, and I'm sending patients to somewhere in Texoma or Fort Worth because the hospitals over here, they're full. I have no place where to send them. And it increases my liability as well. Let's say a kid doesn't find a place where he or she can be hospitalized and they end up committing suicide. It's a high liability for me. It's so hard to find them places. It's so hard to find them IOP or partial hospitalization programs. So I think that's where we need to work more. I stopped seeing teenagers. This is it's not good for teenagers, but how much I can change the system. It's not in my control. And again, my focus is more, I'm an adult psychiatrist. I'm not a child and adolescent psychiatrist. So my focus was more on adult psychiatry and addiction medicine.
It's really sad that the suicide rate for children has gone up double in the last 10 years. I did not know that.
Yeah, a lot of people don't know that. And things are so bad right now with kids in school, self-harm. That's why I'm saying, pay attention to small things. I sometimes see somebody who's not even a patient, a kid of a friend or somebody, and I notice, the cut marks. It worries me. The other thing is the identity issues. A lot of kids, you will see this more and more, the sexual identity issues. They are not comfortable in their own sex. That is on a rise too, by the way. If you look it up, you will see that more and more children, even adults, they have issues with their gender. So a lot of identity issues going on. And when they are not accepted well by their families or by their peers, they are bullied. The next resort is easy access to medications, drugs in school. I had a kid who was 13-year-old when I used to see children. And he said, Dr. Ali, is it okay to take Adderall with Prozac? And I was like, I never prescribe you Adderall. You're only on Prozac. And he said, no, my friend gave it to me and I have an exam coming up. So can I take Adderall with Prozac? And I was like, no, you shouldn't be taking any Adderall at all. And then I had another kid who said, Dr. Ali, I took a medicine prescribed by my dentist. Can you write it for me? It was really good. It helped me a lot with my depression and anxiety. And guess what was the medicine prescribed by the dentist? Hydrocodone or oxycodone, opioids. So they make them feel really good if they have experimented it once or twice. And a lot of time, unfortunately, it is started by a doctor. I had a patient who was a motorbike racer and he had an injury and he was started on hydrocodone by his doctor. And now he's a full-blown opioid addict. He has relapsed so many times and it's very sad. It was first started by a doctor. So I try to avoid opioids if we can.
Thank you for explaining this to us. The next question we have, there's two questions. They're both similar to one of them came from the chat, one of them was listed. So this is about the so which age groups are least likely to seek help when it comes to alcohol abuse and dependence? Also, are there any certain medications that have any alternate effects depending on the age of the patient in question? So regarding seeking help, is there any kind of stigma around seeking help for alcohol abuse or
Oh,
substance abuse?
absolutely, all the time. The more educated, the more stigma. So really, it's people in the healthcare field, they are very reluctant. What is the risk? The risk is they will be reported to the board. It's my responsibility. If I see somebody, as a nurse or a doctor, and I've done that, trust me, Hamza, it is such a painful situation, where I have to do it because I know what your medical license means to me. I know what it means to be investigated by the board, and it's not. The other thing is a lot of time. Then if the license is suspended, it's a whole different process to get it again, and then it increases your. It makes your liability insurance, medical malpractice insurance to go up. So they are very reluctant. Healthcare workers are very reluctant. Nurses, doctors, healthcare workers, lawyers. They are more prone to drinking, but they still they are reluctant to get help. These days, medical boards, nursing board, I'm sure lawyers have the same program. Even pilots. I had a pilot. It was very, very dangerous. You have to report to the aviation department. And pilots are checked randomly. I think for alcohol, they are checked every time, but for drug screen, they are checked randomly. So there's still a possibility that they can use in between. So for doctors, there is in Texas Medical Board has a program. And I had one doctor who was included in that program, but he regretted it so much later on because they really made his life very hard. They will make him do a random drug screen anytime. So let's say he's in the middle of seeing a patient and they will order him and he has to do it within the next 3 or 4 hours. So, and he felt really bad. He said that he felt like he was a criminal who has to go through this drug process. So a lot of time they avoid it as much as they can. And sometimes they try to do it on their own. They try to do it at home, and that's where you see seizures. That's where you see, emergency admissions. So younger people are also very reluctant to get help. Teenagers, because their parents don't know that they were drinking at a friend's house, or they don't know that they have a stolen ID that they are using to get alcohol. So obviously they are very reluctant to get help. So really it depends on what profession they are in. The more the stigma, the more the risk to their job. The chances of getting them asking for help is less and less because they don't want to jeopardize their job, or they don't want to jeopardize their relationship with their parents or their family.
Now, this next question comes specifically from disulfiram because you mentioned that in your presentation. So everybody knows that alcohol already has what are well-known negative effects, yet people continue to drink. So what did disulfiram do different that prevents people from drinking anyways? What causes the fear from disulfiram and drinking?
So, when you are drinking, at least you're getting some good effects initially, right? So you're enjoying the drink with your friends and family or wherever you're sitting, and you keep on drinking. Your blood alcohol levels goes very high. Disulfiram is different because you will get sick even with one drink. And what do they think? When you are treating a patient with alcohol use disorder, you have to think like them, right? So they are thinking, okay, I'm just going to take one drink. I know I have a problem with alcohol. I'm here. I'm just going to take one drink and then I'm going to stop. But they cannot stop. That's what they don't realize. It's genetic. The switch in their brain is different than other people who can stop after one drink. They can't. So with disulfiram, they will definitely stop even after a sip of alcohol. Okay, within 10-15 minutes, they will start getting sick. So that's why it's different. And I have patients who are on antabuse, and they ask me to put them on antabuse because trust me, they don't like. I mean, who wants to be an obnoxious person? Who wants to be hated by their family or burn the bridges? They want to get better. So I have patients who have asked me to put them. They themselves have asked me. These days, patients are more knowledgeable with Google and everything. They will come to you and ask you about specific drugs. So they will ask you for a specific medication to be put on. So again, when you're talking in the doctor's office, a lot of time patients, they are not paying attention, or they have a short attention span, or they forget easily. Best thing is to email them. I do this all the time. I email them all the side effects and I tell them, go home and read it again, so that they're very, very, very aware and they don't reach a point where they get very sick. So that's how disulfiram is different, because it stops the process right in the beginning versus alcohol, where you can get completely drunk and your blood alcohol levels go to 300, 400, and you are now driving under the influence. It will definitely prevent you from not driving under the influence. You will not even reach a state where you're drunk. You will get very sick before that.
All right, and our final question. So for students who did not attend the previous session, you wear many hats. Just today, you've told us that you used to work in inpatient care, but you stopped and you work in outpatient care. So how do you manage your work-life balance?
Very hard question. Most of us, we don't have a very good work-life balance. I think my work-life balance is much better now. As I progressed in my practice, initially it was not good. I will be very honest about it. When I first started my private practice, I didn't have enough staff, because in order to run private practice, you need a lot of support staff. Like I was telling you, Hamza, that I have to send patients to inpatient and my staff is calling them, or my staff is on the phone. Because if you are seeing patients back to back, we have administrative breaks during the day. But if you are seeing patients back to back, you don't have time to sit down and do an hour-long session. A lot of patients, they don't know the difference between a psychiatrist and a therapist. They think I'm here to do talk therapy. So they continue to talk and it's hard to cut down the session. So initially I had a lot of hard time because I only used to have one front desk staff member. Now we are over 50 employees in our practice. So we have a lot of support staff. We have a lot of educated people. My staff is well trained. My staff is very familiar. Initially, I had one person and she was not very well trained about what to do. They didn't know. We had a person who will start crying. Like if a patient is on the phone and telling them suicidal, she will be crying with the patient. So we had to teach them how to take a call. We had to teach them where to direct the patients with suicidal ideation. So it's a thorough training process. Now we have developed the policies and procedures. I have a very good office manager who is very well educated about all the psychiatric issues. So she has long presentations. Anytime we have a new employee, the employee is given orientation. I think that has improved my work-life balance really well. If you don't have good staff, your work-life balance is not good because you're constantly dealing with the issues that you shouldn't be dealing with. Same thing with even hospitals, in the hospitals, if you have a good social worker, she will prepare the letter for you. For example, a lot of these patients who are admitted inpatient, they need a letter from you to go back to work. So if you have a good social worker, she will prepare the letter for you. All you have to do is just sign the letter. But if you don't have good support staff, it's not good. Working for hospitals, I had a really good work-life balance. Let me tell you honestly, by the time I will finish my work at 5 p.m., I'll come home, no phone calls, I'm done. In residential rehab, if you are on call, then the nurses will be calling you all the time to get orders because they cannot even give in an inpatient unit, they cannot even give Tylenol or ibuprofen without doctor's orders, okay? There are some standing orders. If you have entered PRN orders, that can improve your work-life balance. If you have, let's say you have written Zofran, 8 milligram BID PRN nausea, then the nurse is not going to call you. You have PRN orders for that. But if you don't have, if you're not put details order, you will be getting the phone calls all the time. So really you have, and it's very important to work on your work life. I have gone through burnout. 2 years ago, I had reached a point where I didn't feel like going to work. I was very tired all the time. My migraines became very worse. And then I realized that, okay, my work-life balance is the one, and it can happen to anyone. Please, all of you are listening to me, all the medical students, you are not immune from depression. You are not immune from anxiety. We are the ones who are told and taught patient care comes first. You take care of the patient first. Your emotions and feelings come later on. I have seen a therapist myself one time when a patient came to my office and threatened me, and the patient left, and I was really, you fear for your life. My parking is in the basement. So when I will go at the end of the day, there will be no cars in the basement. I will be the last one leaving. And around that time, there was another doctor who was shot in the parking lot. So, you're not immune, and you don't go home and discuss these things with your children. You don't want to tell a 5-year-old that your mom received a death threat today. You don't go and call your parents sitting back home in Pakistan or for some other state and tell them, I received a threat. You don't want to make them worried, right? So and you cannot keep it to yourself. At that point, you need to talk to someone. Please watch out for all the signs of burnout. If you are feeling tired, if you have physical complaints, and work on your health. Nothing is more important than your own health. I realized it later on. Early on, I didn't take care of it. I paid a price. So that's why I'm telling all of you who are out there, please watch your health. If you have a less score in exam, you have failed an exam, so what? As long as you're alive and healthy, you can take it again. Don't worry about that. You don't have to be perfect all the time. It's okay to be imperfect. Things happen. The other thing was during residency, your attendings, some of your attendings will insult you in front of medical students. You will be presenting cases every morning. You will make mistakes. Don't be so hard on yourself. All of us, we make mistakes, okay?
Thank you very much for that advice, Dr. Adi. I really appreciate it. And thank you very much for all these questions. These are all the questions we have for today. And we really appreciate you taking your time out to mentor us. I'd love for everyone to please give a warm thank you to Dr. Adi in the chat box for this incredibly informative session. Thank you.
Thank you so much, guys. It was my pleasure talking to you. Wish you all the best in your careers, okay? Don't be hard on yourself.
Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session is now live, and as always, you'll need a 70% or higher to pass and receive your certification. And that link to the quiz is being sent in the chat now. And for our future session dates, which will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, November 19th at 10 a.m. Eastern Standard Time with Dr. Hay mentoring us in psychiatry. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing. Thank you.